This presentation is titled Hot Babies, a point-of-care ultrasound approach for the febrile infant. We have no disclosures. Fever is one of the most commonly encountered chief complaints for infants presenting to the emergency department. Although the incidence of neonatal sepsis is relatively low, appropriate evaluation and identification of infection, adequate resuscitation, and initiation of broad-spectrum antibiotics is imperative to avoid poor outcomes in this population. The typical workup includes sampling of the urine, cerebrospinal fluid, and blood. These samples are typically obtained via bladder catheterization, lumbar puncture, and venipuncture. However, at times there can be delays and challenges in obtaining the needed sample. We will review 3 cases to illustrate how point-of-care ultrasound can aid in the workup of a febrile neonate. The first will focus on how ultrasound is helpful in bladder catheterization. The second will focus on the lumbar puncture, and the final case will focus on how POCUS can be helpful in obtaining vascular access. Case 1. A nurse approaches you to tell you that she has just tried to catheterize the 26-day-old febrile infant and was unsuccessful. You order a fluid bolus and tell her not to worry. You will ultrasound the bladder before she tries again. Procedures like urine catheterization, lumbar puncture, and intravenous access can be difficult, especially in children that are dehydrated or critically ill, or in EDs where children are less frequently cared for and pediatric trained staff may not be available. Urine catheterization has been shown to be unsuccessful in up to 28% of first attempts. Lumbar puncture failure rates approach 60% in novice hands and almost 40% in experienced providers. Although IO is a rare procedure, it has high rates of infiltration. Point-of-care ultrasound has been shown to accurately measure bladder volumes. It has been shown that using POCUS to measure bladder volume prior to attempting catheterization can decrease first catheterization failure rates from 28% to 4%. A POCUS bladder volume measurement of at least 3 mLs is sufficient to successfully collect 2 mLs of urine, which is enough for culture and routine studies. In order to obtain the bladder volume, first let's talk about the position of the child. The infant should be placed supine or in a recumbent position. Allowing the infant to lie in the parent's lap or arms can help the infant be comfortable and allow you to obtain better images. Additionally, using warm gel may help to soothe the infant and again help you obtain nicer images. Once the infant is in the correct position, you must choose a probe. Either the phased array or other low-frequency probe, such as the curvilinear, can be used to obtain the necessary views. Views include the transverse view, which is obtained by placing the probe in the transverse orientation. Place the probe, as seen in this picture, just above the pubic symphysis with the probe marker towards the patient's right. Alternatively, a second view may be obtained and bladder volume can be calculated by rotating the probe marker 90 degrees up towards the patient's head to obtain a sagittal view of the bladder. Once the largest transverse view of the bladder is obtained, the width of the bladder is measured using the calipers. If the bladder width measures greater than 2 centimeters, the bladder volume is likely sufficient for successful catheterization. Alternatively, you can use the machine or simple mathematics to calculate the entire bladder volume. After measuring the bladder in transverse, as shown on the previous slide, obtain the sagittal view as discussed. In this view, the bladder height and depth are measured using calipers. The total urinary bladder volume is calculated using the formula width times height times depth in centimeters times 0.9, which is the correction factor for the shape of the bladder. Most newer machines have a bladder volume function that will automatically calculate the volume based on these 3 caliper measurements. We, however, recommend for bladder volume assessments before catheterization to simply obtain the single transverse view only. In this case, the infant's bladder measured 4.58 centimeters in transverse after a bolus, as seen in this image. You find the nurse and tell them that the infant is now ready for catheterization. Let's move on to the next case. Case 2, it's July 2nd and you're working with a new intern. A 19-day-old febrile infant's brought to your team for evaluation. In reviewing the workup with the resident, he tells you he has never performed a lumbar puncture, only seen one. You tell the intern that ultrasound can help him be successful with the lumbar puncture. Infant spinal anatomy uniquely lends itself to successful POCUS imaging. The incompletely ossified spinous processes provide a large acoustic window through which clear images of the spinal canal can be obtained. Definitive evidence exists showing experienced operators can use POCUS to improve success rates of lumbar puncture in infants. POCUS has also been shown to help identify safe intervertebral spaces to perform the LP, compared to traditional landmark palpation technique in infants. POCUS can also help in determining the needle depth to reach the appropriate CSF space. Let's review the positioning. The infant can be placed in either the lateral recumbent or upright sitting position, whichever is the position of preference of the provider performing the procedure. A high-frequency linear probe is used for this technique. The views that need to be obtained. First, the longitudinal view. The probe is placed in the longitudinal orientation with the probe marker toward the patient's head, as seen in this picture, along the midline, lower lumbosacral spine. First, the tapered conus medullaris, cauda equina, vertebral spinous processes, and interspinous space are identified. The intervertebral spaces below the conus are evaluated for the largest area of intrathecal fluid. A marking pen can be used to mark the skin at this level. We will show you some pictures of the skin marking in the coming slides. The depth for needle entry from the skin to the subarachnoid space can also be measured in this orientation. Here you can see the estimated distance is just over 1 centimeter. The probe marker is then rotated 90 degrees towards the patient's right to obtain a transverse view perpendicular to the spine, again as seen in this picture. In transverse, identify the transverse processes, scan up slightly towards the head to identify the spinal cord, and then down towards the feet until the conus medullaris and cauda equina are identified in this space as marked. This is a clip scanning down towards the feet until the conus medullaris and cauda equina are identified. After identifying these landmarks, re-identify the conus medullaris and draw a horizontal line at the level it terminates on the patient's back. Marking the skin to identify the midline of the selected intervertebral space is also helpful. At the appropriate level where CSF is identified, mark the midline on the patient's back. Here's a diagram of the skin marking that was discussed. The first line, this horizontal line, represents the termination of the conus medullaris. The cross marking indicates the vertebral space, indicates the intervertebral space and midline point for the first attempt LP. After marking the skin with the resident, he is now more confident in his first attempt at this LP. Let's move on to case 3. A 6-day-old lethargic infant presents to the ED. The infant is febrile and tachycardic to 200 and has a blood pressure of 60/30. Peripheral IV access is unable to be obtained. The fellow places an IO, but staff are unsure if it has infiltrated. Ultrasound can be used to aid in both peripheral IV access and in confirmation of IO placement. Guided peripheral IV access has been shown to result in fewer attempts, fewer needle redirections, and shorter time to successful access when compared to traditional palpation techniques. There is significantly higher first attempt success, 85% versus 45%, in children where ultrasound guided IV placement is used in difficult access situations. Given that emergency physicians are familiar with ultrasound guided IV access techniques, we are going to focus our description on the ultrasound POCUS technique to confirm IO placement in children. IO placement is traditionally confirmed by either aspirating bone marrow or by the ability to easily flush saline into the line. Infiltration is frequent and may go unnoticed until enough fluid accumulates in the subcutaneous tissue to cause limb swelling. Using POCUS to confirm IO needle placement was first described in adult cadaver models. POCUS, however, since has been shown to confirm IO placement in critically ill children. After IO placement, a linear high-frequency transducer is used for this technique. Place the probe in the longitudinal plane or transverse plane as seen in these pictures, just adjacent and distal to the IO needle insertion site. Place a color Doppler box over the cortex of the bone. Then flush the IO with saline, and a flash of red or blue color flow will be seen just deep to the bony cortex. This is a clip of an IO being flushed and confirming its placement. Inadequate placement will demonstrate a color flash above the bony cortex, far deep to the bony cortex, or lateral to the cortex in the soft tissue. If no flow is seen, the angle of the probe can also be adjusted by slightly fanning the probe, as Doppler flow requires velocity to be perpendicular to the transducer. In this case, the IO is successfully placed and confirmed using ultrasound. In summary, POCUS is a useful adjunct in the workup and resuscitation of the febrile neonate. Bladder LP and IO POCUS should be considered to improve success rates of these procedures in the workup of the febrile neonate.